Dr. Naglia. Good morning, everyone. It is a great pleasure to have my colleague, Dr. Nia Heard-Garris, joining us this morning. Dr. Heard-Garris is a pediatrician and a physician investigator at the Ann and Robert H. Lurie Children's Hospital of Chicago and in the Department of Pediatrics at Northwestern University Feinberg School of Medicine. She examines the influence of social adversities experienced in childhood and subsequent child and adolescent health. Dr. Heard-Garris is also interested in the factors that contribute to a child's ability to thrive despite these experiences. In August 2019, she received her Career Development Award, a KO1, which is funded by the National Heart, Lung, and Blood Institute. And with this award, she plans to investigate adolescent cardiometabolic health. She believes in using research to better inform clinical practice and policy that supports children, their families, and their communities. Dr. Heard-Garris is also an active member in the American Academy of Pediatrics and serves as the chair and founding member of the section of Minority Health, Equity, and Inclusion. Dr. Heard-Garris completed a prestigious Robert Wood Johnson Foundation Clinical Scholars Fellowship at the University of Michigan. She earned her Master's of Science in Health and Healthcare Research and a Doctorate of Medicine from Howard University College of Medicine. She also helped to launch the student-run free clinic serving DC residents. Dr. Heard-Garris earned her Bachelor's of Science in Biology at Spelman College in Atlanta, Georgia. Dr. Heard-Garris, her husband and 8-year-old son live in Chicago, and as new Chicagoans, they better understand the phrase, winter is coming, although we've got to get her up to Minneapolis in winter in person sometime so she knows what real winter feels like. Dr. Heard-Garris, thanks so much for joining us this morning, and I'll turn it over to you.
Thank you so much, Dr. Schleifer. I'm so excited to be here with you all today, and I know you understand the pain of just living in the Midwest in the height of winter. So I'm so excited to talk to fellow Midwesterners. So I'm going to be talking about ACEs, structural racism, and resilience, blending scholarship and advocacy. I'm really excited that you all are going virtually to the Capitol because I rarely get to talk about advocacy, but was asked to talk about that in this talk, and so I'm glad that you are all participating in advocacy efforts. So this first slide says Black Lives Matter. It's a colorful Black Lives Matter mural near where I practice in Chicago and Uptown, and I think it's a beautiful imagery, and we'll get into it. So I don't have anything to disclose, or I have one thing to disclose. I am a co-owner of a health equity consulting group called X and Y Genes, but I won't be talking about that. I do have grant funding from the NIH, but I don't have any, I'm not going to discuss anything about off-brand generics or medications in this talk at all. So I just want to say what an amazing privilege many of us have been afforded. We care for our nation's future leaders, doctors, teachers, and revolutionaries. And we also, many of us have the privilege of teaching them. But let's first start with the statistic about them. 1 in 3. A Black boy born today has a 1 in 3 chance of going to prison in his lifetime. A Latino boy, a 1 in 6 chance, and a white boy, 1 in 17 chance. Here's a great visual from the Prison Policy Initiative that shows on the left the makeup of white, Black, Latinx, and Native populations in the US. And on the right, they're the same populations in the prison population. You can see that on the left, 64% of those that are white in the US population then only represent 39% in the carceral system. And then conversely, 13% in the US population that are Black represent 40% in the carceral system. We've got 16% of Latinx individuals in the US population, and then 19% in the carceral system, and 0.9% that are Native or Indigenous, and then 1% in the correctional population. So what about Minnesota? Minnesota has an incarceration rate of 364 per 100,000 people, and that includes prisons, jails, immigration, detention, and juvenile justice facilities. Nationally, that rate is 698 per 100,000 people. And on the surface, I was impressed because I'm in Chicago, I'm in Illinois, and our rate is closer to 600. I think it's like 646 per 100,000 people. But honestly, for African Americans in Minnesota, the reality is much worse. So here's another visual from the Prison Policy Initiative. Here you can see, and this is racial and ethnic disparities in prisons, jails in Minnesota. So 83% of those in the state that are represent the white population, but in the correctional or carceral system, 47% of those individuals are white. While conversely, in the state population in Minnesota, 5% are Black, but represent over 30% in the correctional population. And you see Latinx is about 5%, and they represent 12% in the correctional population. And the Native individuals are 1% and represent about 8% in the carceral system. So here's this information presented a slightly different way, again, from the Prison Policy Initiative. This shows the number of people incarcerated per 100,000 of that racial and ethnic group. So here you can see Black people in Minnesota have an incarceration rate of 2321 per 100,000 people, and American Indian and Alaskan Natives have a rate of 2646 per 100,000 people. So I know you're thinking, okay, Dr. Heard-Garris, these numbers are staggering, but we're talking about this at a grand round. So we're talking about ACEs, we're talking about equity. So why are you starting with that? So we'll come back to this. So first, let's set the scene. So by the end of this talk, I expect that you'll be able to list 2 or 3 examples of the original and expanded adverse childhood experiences, or ACEs. You'll be able to describe the relationship between ACEs and health. You'll be able to discuss ACEs and racism and how they intersect and influence the health of children and adolescents. And finally, I'm excited to talk about this, to illustrate how to use advocacy and voice to highlight important issues for individuals impacted by ACEs and racism. I rarely get to talk about advocacy, so I'm so excited to get there. So we're going to start with some background on ACEs. The original Adverse Childhood Experiences, or ACEs study, was conducted between 1995 and 1997. It included about 17,000 patients receiving health maintenance or checkup exams in Southern California. And the study's lead author, Dr. Vincent Folletti, found that certain adverse experiences were common in childhood. These experiences were categorized into 3 groups: abuse, neglect, and household dysfunction. I don't love that last name. I would say household problems. Those are then categorized further into physical, emotional, and sexual abuse, physical and emotional neglect, and household problems could include household members with mental illness or incarcerated relatives, domestic violence or having a parent treated violently, household members with substance abuse problems, or if your parents were divorced. These individual ACEs are added together to produce a score. The score doesn't take into account the frequency of exposure, just if a particular type of ACE was present or not. So as you can see on the list, incarceration is on the original list of ACEs. And that's why we began the talk with incarceration, and we'll continue it a little later. So we talked about the original ACEs, but we know through Dr. Vincent Folletti's study that the initial ACEs, or the original ACEs, may not have adequately encompassed the breadth of adversity that minority, low-income, and urban children experience. Dr. Vincent Folletti's study was mostly white, middle-class, suburban men in that study. And so we recognize that those experiences might not be inclusive to the larger population. So Dr. Roy Wade and his co-authors helped to capture additional experiences known as the expanded ACEs. These include discrimination, economic hardship, negative life events, parental psychopathology, bullying, and community violence exposure. So why do we care about ACEs? We care about ACEs because ACEs both impact the individual person, but also the larger community. When we examine at the individual level, we're talking about the influence on genes, the brain, health behaviors, and health outcomes. I'm not going to focus much on the epigenetic changes or brain architecture today, but just know that's a whole big field and people are doing that work. It's really quite interesting. Instead, we're going to focus on the direct and indirect influences ACEs have on health, including health behaviors, health conditions, and healthcare use. We're going to touch on these a little later in the talk, but just so you can understand what I mean, people with ACEs are 10 times more likely to use illicit injection drugs and 7 times more likely to struggle with alcoholism. They're twice as likely to have ischemic heart disease or stroke, and they're 1.5 times more likely to have diabetes or cancer. So now you know what ACEs are, both the original ACEs and the expanded ACEs. You know why they're important, or at least why I think they're important. And these might be topics you've already known or you've already heard many, many times before. But we're going to talk about something that's less frequently discussed within the context of ACEs, which is the intersection of ACEs and also racism. In order to fully address health equity, we have to discuss and address the systems of inequity that exist to perpetuate health inequities and disparities. So I'm going to use some of my early work and the work of others to demonstrate why I think ACEs should not be talked about without a conversation about race and racism. So I showed you before that discrimination is included as an expanded ACE, and researchers and physicians should consider the influence of racism on child health. But as we mentioned, ACEs can have an impact on the individual, but also have an impact on the community level. And I really see the clearest manifestations of racism as an ACE at the community level. So I really love this graphic. I borrowed it from my colleagues at the University of Chicago. And here at the top, it may be a little cut off. It says 3 layers of adversity: adverse childhood experiences, social determinants of health, and historical trauma. So I like this because adversity is conceptualized as a tree. And if you start at the very, very bottom, that's the soil. The soil's adverse collective historical experiences. And that's experiences that a group may experience together, like slavery or genocide or mass incarceration, the displacement or the Holocaust. And the roots of the tree are in that soil. And the roots are adverse community environments. So that's racism and discrimination, community violence, the lack of educational, economic, and housing opportunities. And so then that tree with those roots that's in the soil then give rise or sprout the leaves and the branches. And that's pictured here as adverse childhood experiences, which are a lot of the ACEs we just talked about. So again, the soil is the collective historical experiences, the roots are the adverse community experiences, and the leaves and the branches are adverse childhood experiences. So as we mentioned, the roots of our adversity tree, which are adverse community environments, include racism. This next graphic demonstrates how racial discrimination materializes into individual level health problems. This is a very text-heavy graphic, so I'm going to walk you through it. So this is a conceptual model of how racial discrimination essentially gets under the skin and impacts health. So first, a child is exposed to racial discrimination, and that can happen at the microsystem level, the individual level, or the macrosystem level, the community or structural level. So in the microsystem level, a child can be exposed to discrimination via bullying, name calling. So that's what people typically think of when they think of racism, like you called me a bad word. But also children can be exposed to racism or racial discrimination through the observation of a parent. So for example, if a parent or a peer is experiencing racism and the child witnesses that, that is also exposure to racism or racial discrimination. And also the type of parenting a child receives. So that is called racial socialization. So what does it mean for me to raise my son to grow up as a Black boy in this world? I teach him either directly or indirectly the rules of how to move through the world as a person of color, as a male in this world. And so that is racial socialization, that's parenting. So you can be exposed to racism and preparation of racism in that way. Or you can be exposed to racism at the larger level, the structural level. So that's through the media, through schools, through our social and political and economic policies, and then also through police and other adults. So those exposures then fold into psychological distress and biological responses. So some of that biological responses include decreased immune function, increased cortisol levels, increased blood pressure, and increased heart rate. And some of those mechanisms are actually quite similar to what we think is happening with adverse childhood experiences and how they go on to influence health. So taken together, the psychological distress and the biological changes or responses to racism then give rise to health outcomes and subsequently disparities. So those that are exposed to racial discrimination might have an increased likelihood of giving birth to a child that's low birth weight or premature, increased risky behaviors like drug use and sexual risk-taking, aggressive or violent behaviors, chronic illnesses like cardiovascular disease, and increased susceptibility like HIV, and also we're seeing COVID-19. So I'm going to give you two specific examples where I think particularly ACEs and racism then intersect. In these examples, racism as an ACE influence health behaviors, overall health, and healthcare use. So we're coming back to where we started. We were talking about incarceration at the beginning of this talk. And while it's true, the incarceration of a parent is considered an original ACE by Dr. Vincent Felitti, I want you to also understand that this specific ACE has a disproportionate impact on children and families of color. So first, I have a question for you. Dr. Schleifer can't answer. Think about this in your head. I want to know how many US children have had a parent incarcerated. I want you to think about that. And I should add that they've lived with. So I know we're on Zoom, so you can't shout it out. Just think of a number. Okay, you got it? 5 million. Were you right? It's 5 million. 5 million children in the US have had a parent that they've lived with go to jail or prison. This figure is the most updated number we have, and it's from 2015. And we know it's an underestimate because the rates of incarceration in certain populations are rising. And it doesn't take into account the number of children who have had parents that have not lived with them go to jail or prison. And the US has the highest incarceration rate in the world. And we know that Black and Hispanic children, rural children, and low-income children experience disproportionately high rates of parental incarceration. And while the majority experience incarceration of their fathers, maternal incarceration is increasingly more common due to the rising incarceration rates of women. So I wondered, how does incarceration of a parent influence the health of a child as they grow up, so as they become young adults? There's a growing body of literature that indicates that parental incarceration is detrimental to the health of individuals that have parents that go to jail or prison. Specifically, the prevalence of asthma, HIV/AIDS, depression, anxiety, and PTSD is higher among individuals that have had a history of parental incarceration. So for this specific study, I asked, what is the relationship between the incarceration of a parent in childhood, so before the child was 18, and healthcare use and health behaviors in young adulthood? And does the relationship change according to which parent was incarcerated? And so for this study, I hypothesized that individuals with parental incarceration would have lower levels of healthcare use and higher prevalence of unhealthy behaviors compared to the peers that didn't have a parent incarcerated. And I also hypothesized that those with mothers that were incarcerated would have much stronger associations to negative outcomes than those with fathers. So for this study, we use AdHealth, which is a nationally representative survey of children in high school into adulthood, and it began with almost 19,000 students, was successfully followed up nearly a decade later with almost 14,000. And for our study, 13,000 were in our sample. At Wave 1, respondents were asked if their biological mother or father ever spent time in jail or prison. We included individuals who reported any history of mother or father incarceration after birth, but prior to age 18. And we created variables of mother incarceration, father incarceration history separately so we could understand the impact separately. We examined healthcare use and 3 dimensions of health behaviors, which were general health behaviors, substance use, and other high-risk behaviors, which were all collected in Wave 4. Within healthcare use, we examined primary healthcare, dental healthcare, and mental health care. And for mental health care, they were asked if they received psychological or emotional counseling within the last year. We examined general health behaviors of TV use, sugary drink intake, and sunscreen use. Regarding substance use, we examined cigarette smoking, problem drinking, prescription and illicit IV drug use. And then our final dimension of health behaviors were other risky behaviors, including the number of lifetime sexual partners, sex in exchange for money, and gambling problems. We controlled for wave 1, sociodemographic factors like age, race, gender, and also family structure. So coming from a 2-parent household, a 1-parent household, or no biological parents in the household, parental education, receipt of public assistance, and geography. So that's urban, suburban, and rural. We use multivariable logistic regression, controlling for those covariates, and examine that relationship between parental incarceration and healthcare use and health behaviors. The highest percentage of those that had mothers and fathers incarceration histories were non-Hispanic Black individuals, those from single parent households, households that were receiving public assistance, and those in urban settings. If you remember, we examined primary healthcare, dental healthcare, and mental healthcare use. And for primary healthcare, we found that young adults with any history of parental incarceration had higher odds of needing medical care but not receiving it, while young adults with mother incarceration histories had 2 times the odds of using emergency room or non-primary care setting for their usual source of care. For dental health care, young adults with mother incarceration histories had lower odds of having dental exam within the last year. And then for mental health care, young adults with father incarceration histories had higher odds of mental health counseling within the last year. We examined general health behaviors of TV use, sugary drink intake, and sunscreen use. Regarding TV use, and this was before Netflix and before COVID-19 pandemic, young adults with father incarceration histories were more likely to watch 50 hours or more of TV per week. For sugary drinks, young adults with father incarceration histories were more likely to drink 4 or more sugary drinks per week. And regarding sunscreen use, those with father incarceration histories were actually less likely to use sunscreen. We examined substance abuse as well. For cigarette smoking, young adults with any parental incarceration history had over 1.5 times the odds of smoking cigarettes and higher odds of problem drinking for both. For prescription drug use and IV drug abuse, young adults with any history of parental incarceration had higher odds of abusing prescription drugs, while those with father incarceration histories only had higher odds of IV drug use. Our final dimension of health behaviors were other risky behaviors. Regarding the number of lifetime sexual partners, any history of parental incarceration was associated with 10 or more lifetime sexual partners. And regarding sex in exchange for money, young adults with mother incarceration histories had 2 times the odds of having sex in exchange for money. And for gambling problems, that is gambling causing serious financial problems or problems in relationships with friends or family, we did not find an association between parental incarceration and higher odds of problem gambling. So young adults with a history of parental incarceration during their childhood were more likely to skip medical care, misuse or abuse prescription drugs, and engage in risky sexual practices. Following the first parental incarceration study, we wanted to understand the relationship between direct and indirect exposure to incarceration. So meaning juvenile justice involvement versus parental incarceration. And I was so excited that I got to work with Dr. Schlafer on this paper and another colleague, Dr. Tyler Winkleman, on this paper as well. They're experts in this field and some of University of Minnesota's finest researchers. So for this study, we asked, what is the relationship between the exposure of juvenile justice system involvement? So that's a direct exposure. You yourself were involved in the carceral system, and parental incarceration in childhood, which is an indirect exposure, and mental health conditions in young adulthood. And is there an additive effect for those who've experienced both parental incarceration and juvenile justice involvement? So you being involved with both, having both that indirect and direct exposure, is that cumulatively worse for your mental health? And we hypothesized that individuals with both juvenile justice involvement and parental incarceration were more likely to have adverse mental health conditions, and that those exposures would be additive. We use AdHealth again for this study, and we controlled for similar factors. We use the same parental incarceration variables from the first study, and also for juvenile justice involvement, we used respondents that were asked about arrest, conviction, or pleading guilty to a crime, or been found guilty in juvenile court before they were age 18. So we examined depression, anxiety, PTSD, suicidal thoughts, suicide attempts, and the receipt of mental health counseling. We controlled for the similar factors as we did in the first study. And we found similarly that those that have had parental incarceration and juvenile justice histories were more likely to be non-Hispanic Black individuals, those from single parent households, those from households receiving public assistance, and in urban settings, almost exactly the same as what we found before. And we analyzed our respondents by groups of exposure. So those that were exposed to parental incarceration only as an indirect exposure, those with juvenile justice exposure only, and those with both parental incarceration and juvenile justice exposure. And for all of these three groups, we found that both the direct and indirect exposures were more likely to have an impact on adverse mental health. So for many, that's depression, anxiety, PTSD, and suicidal thoughts and suicide attempts. And also we found that mental health counseling was higher in these groups. So we hypothesized that these exposures, so parental incarceration and juvenile justice involvement, would be additive. So if I had a parent incarcerated and I myself was incarcerated, I would have a greater impact on my mental health. But for this study, we actually found that those exposures were not additive. We also found that 1 in every 100 US children experienced both parental incarceration and juvenile justice involvement. Ultimately, we found having juvenile justice involvement and having a parent incarcerated was associated with adverse health conditions, which we just talked about: depression, anxiety, and PTSD. So these findings suggest that there's a relationship between incarceration and adverse healthcare use, health harming behaviors. And depending on which parent is incarcerated, I hypothesized with the first study that it would be more detrimental if it was the mother incarcerated, but we found significant health harming behaviors for those that had a parent, a father incarcerated. So not just mother, but a father incarceration history is important for health. Incarceration is an ACE that has roots in structural racism because of the disproportionate impact on Black and Brown children. Adverse health harming behaviors, healthcare use, and undesirable mental health conditions disproportionately may impact these groups because of the way incarceration is inequitably distributed across our population. So Black and Hispanic children, rural children, and low-income children are more likely to have these health harming behaviors and underutilized healthcare. And we know that, again, because of the distribution of incarceration and carceral system exposure in these groups. And there's similar disparities seen by income and geography as well. But so we know that there are many risks for becoming an incarcerated individual, and one of those risks is having a parent incarcerated. But there's also protective factors. So this study is under review with a colleague in California, that there are adolescent protective factors against incarceration onset. And what we've seen so far is that higher incarceration frequency, mitigating those factors were revolving around education. So a higher grade point average and plans for the future. So plans to attend college were mitigating the exposure or the risk of becoming incarcerated or re-incarcerated in this population. Risk factors included the ACEs, so physical and sexual abuse in childhood, parental incarceration, and the like. So we talked about the intersection of parental incarceration and race and racism. In the next example, we're going to discuss the relationship between environmental racism, a specific negative life event, and health. So in my opinion, the Flint water crisis is a story about environmental racism, which shows up as community divestment and community of trauma and community trauma. So in 2014, the state of Michigan decided to save money by switching from Flint's water supply Flint's water supply from Lake Huron to the Flint River. And locals, many knew that many thought that the water was dirty, and the switch was made during a state of financial emergency for the struggling industrial town. It was supposed to be a temporary switch, but soon after the switch, the water started to look, smell, and taste funny. Residents often said that it looked dirty, and it was because the Flint water was not being treated with an anti-corrosive agent, which was actually in violation of federal law. So therefore, the water was eroding the iron water mains, which was turning the water brown. And because half of the service lines to Flint were in homes, were made of lead that were in those homes, and the water wasn't being properly treated, lead began to leach into the water supply. And the area of Flint is a minority community and also low income. And at the time that I was doing this study, I actually was in Ann Arbor and working at the University of Michigan. And so asked myself, would this have happened, along with many other people, would this have happened here in Ann Arbor? So this is a picture of the Flint water plant, and the quote says, "Water, water everywhere, nor any drop to drink." So for this study, this was an ongoing study that was happening in Flint, but we latched on to that study and surveyed 100 adults impacted by the Flint water crisis, enrolled in this larger ongoing study in the emergency department to understand if the Flint water crisis, if they thought that the Flint water crisis impacted their health, but also the health of their children. The population was mostly in their mid-20s, African-American females, and with children on public assistance. The entire study is much larger. It focused on coping, financial burden, and health problems of adults that were living in the Flint water crisis. But today, I'm a pediatrician, so we're going to focus on the concerns that parents had for their children. But I wanted to show you this because it was larger than what we're going to talk about. So here I'm showing you what the parents said about how they felt that the Flint water crisis impacted the health of their children. So nearly 40% felt like there was an unexplained change to their child's health since the Flint water crisis. It included rashes, abscesses, stomach, and digestive issues. But only about 20% went to the doctor for their health concerns. And it led us to wonder, with the community adversity and the community trauma and these direct health implications for their children, why such a large group did not go to the doctor. And we don't know the answer to that, but the long-term health and behaviors, we will have to see over time how that impacts that generation of Flint residents over the long term. The crisis is still fairly recent, so we're going to have to follow them out. So that was an example of environmental racism impacting the health of communities, but also impacting the health of children directly. But what about experiencing racism indirectly? So when I was in high school, an unarmed Black teenager named Timothy Thomas was killed by a white police officer. And the aftermath of that shooting was rioting, high racial tensions, a curfew for the city, and essentially left the city divided, and it left a huge impression upon me. And I know where you are too, you've experienced similar events. So that, in addition to in residency, I was pregnant with my son, who's now 8, so aging me a little bit, but Trayvon Martin was killed. And I was pregnant. I think I was maybe a second-year resident, and I was devastated. I was trying to understand how, even though I didn't know Trayvon Martin, I wasn't from Florida, how the impact of him being killed impacted me. And I think it was because I was nervous. I was like, I'm having a Black son in this world who is not ready for him. And so because it impacted me in that way, I started to ask, well, how does it impact others? How does seeing racism, even though it doesn't happen to you, but you're hearing it or experiencing it through the media or some other way, impact your health? So that led me to study vicarious racism. So experiencing racism secondhand or vicariously through someone else. And so I set out to answer the question, what is the relationship between vicarious or secondhand racism and child health? We reviewed over 1,400 articles to understand the state of the literature. We found that almost 50% of the studies showed that vicarious racism was associated with decreased healthcare utilization, worse socioemotional health, and worse mental health. But that was just telling me the state of the literature. I wanted to get a little bit deeper and understand, what are our adolescents seeing? What are our adolescents feeling, especially in the context of the last few years with the heightened video sharing, social media with respect to racism. So I actually worked on this study with one of our fellows here at Lurie at Northwestern, and we were trying to understand, how do teens characterize news? What are their experiences with social media that focuses or depicts racism, and assess their perceptions of how does vicarious racism impact their health? How do they think it impacts their health? So for this study, which is in press, we did focus groups with 18 teens. They were ages 13 to 19, and they were recruited for participation in the focus groups. We had 4 focus groups. We recorded them, transcribed, coded them using qualitative methods. And we found that youth spend much of each day online and frequently access social media, which a lot of us know, but that includes news shared on the platforms. And many participants readily identified being exposed to racism through media and through news. So some of their concerns were about fake news. So here in this pyramid, you'll see some of our themes. So some of their concerns came through about being exposed to or being concerned about sharing fake news and thinking about what's real, what's not real. Participants also reported encountering racially charged news and spoke about their responses to that news. So some reported saturation, like there is so much news and we're bombarded constantly with images of racism or stories that are racially charged. And so they reported the feeling of being saturated by this news. And others reported being helpless or feeling helpless in response to that oversaturation of news. And then finally, it was less obvious the connection between health and these racially charged stories and vicarious racism, but some did report having negative mood, feeling like there's 1,000 or a ton of bricks on their back. Some of them felt like, they were, one of the participants used the term melancholia. So she felt like, because of her color, because of the exposure to vicarious racism, she was in a perpetual state of sadness. So, this was a work that we have just done, and it will be interesting too to see how that work might change in the wake of June 2020, Black Lives Matter protests becoming more on the forefront. This study was done about 2 years ago. So both of my work with the Flint water crisis and vicarious racism actually overlap. I'm working on an ongoing project in the city of Ypsilanti, which is about 65 miles from Flint. We're asking women, pediatricians, and social service organizations about the influence of the Flint water crisis on women and children outside of Flint. So trying to understand structural vicarious racism. How does an event of environmental racism that did not happen to you in your community impact you? And as a pediatrician that was practicing in Ypsilanti, anecdotally, I can tell you that people switched, they stopped using their tap water, they bought bottled water. They were saying, if this could happen in Flint, that certainly can happen in Ypsilanti, which is also has a large population of minorities. So already that mindset changed, like we can't trust the water. I haven't talked much about my career development award, but we are trying to assess ACEs on an individual level and test an intervention on an individual level. So trying to understand the relationship between ACEs and cardiometabolic health in adolescents. So a lot of the work on ACEs have been done in adults. So adults report and say, yes, these things have happened to me in my childhood, and this is what my health looks like now: cancer, diabetes, stroke, so on. But I'm trying to understand what is happening in adolescence, so hopefully a little more proximal to the ACE, so we can understand what's happening, what are the changes biologically or physiologically closer to the events. So also, we are hoping to examine and pilot an intervention that equips adolescents who have ACEs to develop coping skills and stress reduction skills so that they can thrive despite having ACEs. And the intervention and my work that I've mentioned so far is really working at that top level, that adverse childhood experiences, but we still must contend with community and historical levels. So the branches, we need to contend with the roots and the soil still. But we know that adverse community environments can lead to the presence of trauma in many communities. Community trauma is not just the aggregate of individuals in a neighborhood who've experienced trauma. So we all live in the same neighborhood, you experience trauma, I experience trauma, that's community trauma, that's not it. There are many manifestations of community trauma at the community level. So for example, symptoms present at the social cultural environment level, the physical and built environment level, or the economic environment. So for example, with economic and educational equitable opportunity, that might be intergenerational poverty, long-term unemployment, relocation of businesses and jobs, limited employment and disinvestment from communities. For the physical and built environment, that might be unsafe public spaces or unhealthy products present in that environment. And the people that are living in that environment of community trauma might have lower social cohesion and a lower sense of collective and political and social advocacy, like feeling like they can actually make a change in the community, not having those feelings of helplessness associated with community trauma. And so because of the work I do with ACEs, with racism, I feel compelled to do the work of advocacy in using scholarship and voice to influence change. Again, I'm so excited to talk about this because usually in my research talks, I don't talk about the advocacy work that I'm engaging in. But child advocacy represents actions that promote child health and welfare on a population level, distinct from the individual patient level advocacy that we may do day to day. So trying to get prior auths, trying to make sure our patients get their medicine filled, but really that higher population level work. So this is the evolution of a scholar activist that I made up. On the left, it shows a scholar. In the middle, it's a public intellectual. On the right, it's a scholar activist. A scholar are many of you who are a person who pursues academic and intellectual activities, particularly those that develop expertise in that area. Dr. Alan Lightman of MIT says, when such a person, such a scholar, decides to write and speak to a larger audience than their professional colleagues, he or she becomes a public intellectual. And then Dr. Rebecca Farnham wrote that a scholar activist differs from the public intellectuals. Public intellectuals offer commentary on society. They work to make academic knowledge accessible and relevant to the public. But scholar activists go a step further by actively engaging the communities that they work with. When I began my journey in public-facing discussion, I joined Twitter. I posted a little bit about me, what was important to me, what I was doing, and of course, what I study. So this is a picture of me getting the COVID-19 vaccine. This was a tweet that explained why I study health equity. And it just says, the sentence beautifully explains why I've shied away from studying health disparities, because in a vacuum, it's easy to ignore or deny the impact of racism on named disparities. However, health disparity scholars built a foundation on which health equity scholars stand. So I tweet academic stuff, fun stuff, a Black Lives Matter flag outside of my house, a promotion I got, and then of course the work that I do, of course what I study. Then I started to dip my toe into op-eds because 140 characters, and now I guess Twitter's 280 characters, was never enough for a long-winded academic like me. So we started to write op-eds. This was response to Alton Sterling, Philando Castile. This was response to the 2016 election. This was response to Charlottesville. And then I got more formal training in writing op-eds through the op-ed project at Northwestern. And if you have the opportunity to get this training, please do. It's phenomenal. I would highly recommend it. It's about writing op-eds, but it's really more than that. It's about how do you make change in your community. So this was an op-ed project I got to work at with Rush. We talked about the response to SUID, which is sudden unexplained infant death. This one was about vaccines and how they're just as political as gun violence. This one was about incarceration, who's not coming to dinner. It's parents that are incarcerated. They're not going to be able to spend Thanksgiving dinner with their parents. And some were really fun. This was the one I wrote that I still really love. I think it's my favorite. It was talking about a song, Old Town Road, a story of Black life and allyship in America, a partnership between Lil Nas X, a rapper, and Billy Ray Cyrus, a country singer, and talking about how working together can actually impact change. I said yes to opportunities to discuss my research on TV. So in Newsy, or at least racism, I was able to do a piece with Sesame Street and CNN, which was fantastic. And news, this one was about not dodging hard conversations with responses in response to shootings. This was in El Paso and Dayton, those shootings that happened. Or radio, again, this was about Alton Sterling and Philando Castile, how to talk about racism, and NPR, how to, what's happening with ACEs, how are Illinois adults impacted by ACEs. And this one was one of my most recent, how to talk to kids about insurrection and impeachment. And finally, I also want my efforts to influence policy. For me, it's not enough just to talk about it. I want us to actually impact political change. So whenever asked to testify, I try to say yes to that. Ohio is my home state, so I've gotten the opportunity to testify there on behalf of racism as a public health crisis, and then also Illinois. I was recently asked, because of the work that Dr. Schlafer, Dr. Winkleman, and I were able to do, to join the Illinois Lieutenant Governor to talk about parental incarceration and to actually create a policy and task force that tries to help mitigate those negative health and negative educational and life events that happen as a result of having a parent incarcerated. So I'm trying to move from beyond just being a public intellectual, but also a scholar activist, someone who's out there doing the hard work of making change. That's my goal for this year. There's so many organizations to get involved in. This is within Chicago, but Minnesota is one of my favorite places because they're even more progressive, I think, in many ways, and have many opportunities for engagement within the community outside of the walls of the hospital and academia. And when I presented the evolution of scholar activists, it was a little tongue-in-cheek because I recognize we need all areas to produce societal change. We need the evidence in scholarship and the translation to public knowledge, which is the public intellectualism. We need the public will to change it, which is the scholar activism. And then really the policy movement to see things change. I'd love to know what you will do and what was within your sphere of influence, what's going to happen when you go to the Capitol in pretty soon, and how you're going to make change where you are. So George Floyd, Breonna Taylor, my patients and yours all deserve better. We have to do better for them, those youth and the next generation of youth. Adversities in childhood are rooted in historical and modern day experiences that continue to contribute to poor health in adulthood, and multi-sector strategies, including education, public health, research, medicine, and policy are required to disrupt this negative trajectory. This will take committed scholar activists, community, and policy leaders. And so many thanks for everybody, all my co-authors and the faculty and staff that support me. This is our lab. We just launched our website, so you'll see a little QR code. You can take a picture of it and it'll take you to the website. It's called ARISE Health Lab, Adversity, Racism, Inequity, Structures, and Empowerment. That's what ARISE stands for. These are the people that helped me to do this work, so I'm very happy to have them. And with that, I will take any questions.
Thanks so much, Dr. Heard-Garris. That was fantastic. Dr. Berman-Shope, are you moderating the Q&A? We've got at least one question that has come in, as well as a shout out from Brian, who says, I loved this presentation very much. Thank you, and I agree.
Sure, I'm happy to. I have gotten lots of practice fielding our questions. This one comes from Gail Brotman, who is a general pediatrician and pulmonologist at Hennepin Healthcare. She asked it a while ago, so you'll have to remember back to the middle of your talk. She was wondering about the protective effect of future plans and wondered if that only applies to attending college or is any post-high school planning helpful?
That's a great question. We're still doing this work, so we're not done yet. I think for this particular study, we only have plans for attending college. I don't think we have plans for trade school or plans for other careers outside of college. But what I know about the resilience research, and I didn't talk about this because I didn't have time, but we know from the resilience work of many people, Dr. Maston and those that are in that field, that plans for the future in general are protective for children, and not specific to incarceration, but just with respect to boosting resilience. So having an adult mentor, having plans for the future, hoping for something bigger, something outside of yourself, definitely helps children boosts their resilience. And there's many other factors. So I don't want to say it's only education and only saying, I want to go to college, but it's, having family meals together, having someone who believes in you. Those other things are important too. We just didn't study them within the context of preventing or mitigating the impacts of incarceration.
Great, thank you. This one comes from anonymous attendee, but I feel like they ask it on all of our behalves. Clearly, distance learning for nearly an entire year will have adversely affected all children. Are you concerned it will have disproportionately affected Black children? And if so, what on earth can we do about it?
That's a fantastic question. And I think that's on like all of our minds, and anecdotally just having kids and being a pediatrician and seeing the inequity, right, with respect to distance learning. So in Chicago, we tried to make sure that everybody has an iPad or a tablet to be able to do remote learning, but not everybody has really great internet, and other people have not even logged on all year. So we're in February, the school year's almost over, and people haven't even logged in. And I don't know what the different stats are, but I can definitely guess that racial and ethnic minorities and those that are in low income or low resource environments are going to be disproportionately impacted by virtual learning. And what can we do about it? I think there's been a lot of postulating, like, should kids go to school all year this year? Should, we think about new and creative ways to educate our children? And I say, yeah, I think we need to think about how do we fix this? Because, to have kids that have not logged in all year or not being able to have the same educational support. So I've got patients that have IEPs, they need extended help with certain things, they're not getting the services that they were supposed to be getting. I definitely think it's going to impact our children, all of our children, but certainly those that were kind of disadvantaged from the beginning, whether that was because of the school system or because of the community or family that they're within. Yeah, I don't have a good answer. I kind of feel like that was a non-answer, but I don't know.
Yeah, it's something we'll all have to work on together, I think. This one comes from one of my general pediatrician partners at University Children's Clinic, Katie Sadak. What screen do you recommend for screening for ACEs in primary care?
That's a great question. I think in all great science answers, it depends. I think there are some practices that are willing to jump in and ask like all of the questions. And there are some practices that are trying to figure out where to start. And so I give the advice, it kind of depends on where you are as a practice. So some people are worried that if they start to screen that they're going to get yeses, which is true. But then what do you do with the yeses? And practices want to be able to respond compassionately and effectively for kids that say, yes, I've got a parent incarcerated. And then what do you do when you get that yes? So there are some practices that I recommend just starting with one screening. Whether that's a social determinants of health screening, talking about food security, or whether that's talking about, something like, are you able to pay your bills? So thinking more like that, because social workers and resources exist for some of those things. But if you're ready to do full screening, there's the ASK questionnaire and the AAP. If you all are members, they have a toolkit that has a whole bunch of different screening techniques and that are screening tools that you can use to decide which one's best for your practice. In my practice, we have the ASK that is actually, I think they've pieced a couple of different screens together, but we ask about the ACEs of the parent and we ask about ACEs of the child, and that includes parental incarceration, but unfortunately does not yet include racial discrimination. So even within like our own practice, we were debating and discussing what's right for us and what can we provide resources to. I think the racial discrimination one will be changing soon, so happy to report that. But yeah, it really just depends on where you are and how far you are doing this work and what resources you can provide when you get positive screens. We always try to pair a positive screen with some sort of action item, even if it's just a referral, like here's the number of a food bank, here's the number of a lawyer who works with Lurie, that sort of thing. So it just depends where you are.
Great, thank you very much. This question comes from Dr. Lydia Nahara, one of our nephrologists. Does the reason for incarceration change the risks for children? Do the risks change if the child was placed in foster care or cared for by a family member?
Great question. I haven't looked at that. I'm gonna punt that to Rebecca. Do you know?
Yeah, I don't think that the evidence there is particularly strong, in large part because we know that there are a number of variables when a parent is incarcerated, and it isn't just, right, which parent is incarcerated, but it's also when in the developmental course, for how long, the reason, where the parent is incarcerated. And so I do think we know that, kids being placed with stable caregivers, most often kinship caregivers, can be really protective for kids who are experiencing parental incarceration. But we also know that there are some challenges when kids are placed with family members, when those family members may also be experiencing challenges with basic resources and basic needs. So it's really complicated. I think stability in that caregiving relationship is the number one protective factor there in sort of helping kids stabilize when a parent is incarcerated.
I agree. And I think we also know too, like when a father is incarcerated, the kids generally are cared for their biological mother, not always, of course. But then when a biological mother is incarcerated, then those kids are more likely to go into the foster care system, right? And so it also is tricky depending on what resources are there. If the mother is the primary sole, caregiver, and then she's incarcerated, then what happens to those kids? So having that adult, that trusted person, that stable relationship is important, and might be more difficult depending on the circumstances of that incarceration, for sure.
Great, thank you. I think we have time for one more question. I'm first going to say that Dr. Sue Berry from our Genetics and Metabolism Division shared my encouragement to come to Peds Day at the Capitol and how important our voices and respected they are. But there's a couple of questions about resiliency that I think would be a wonderful way to wrap up. So Dr. George, who works in our PICU and in our Center for Safe and Healthy Children, and Dr. Borowski in our Division of General Peds and Adolescent Health, just wondered about how can we promote resilience, a term called vicarious resilience from one of our colleagues, Dr. Svetez. So what are the things that we can try to be doing and thinking about or recognizing in terms of resilience in our patients and families?
Absolutely. I think that's a great way to end this. And I usually talk about it because I have more time to talk about the resilience piece. So I didn't really talk about it today. But I think in general, as pediatricians, there's so many things that we already do to promote resilience, and we may not think about it as promoting resilience, but certainly we could be more intentional about it. So for example, general pediatricians might promote developing, family and school routines for children. So making sure that there's time spent together with meals, or making sure that kids are able to express important ideas or ideas with their family. That promotes resilience, right? So having that strong, trusted family or adult or caregiver is important. Obviously, not everybody has that. So particularly families that are impacted by multiple systems. So whether that's the foster care system, the carceral system, or just ACEs broadly, might not have that stable kind of family unit there. So thinking about the community, how can you tap into community level resources? So whether that's big brothers, big sisters, whether that's talking about joining an exercise group, having kids do the YMCA, those are kind of scaffolding to help promote resilience. So it's not always, do you need to go to their house and do a home visit, right? Those are certainly helpful. Home visits are helpful, but there are little things that you can promote every day. Like, can you teach your kids, your patients about relaxation and breathing and mindfulness when they're facing a stressful situation? Obviously, it doesn't take away that situation, but how can they cope with it, right? How can they deal with the stress and the anxiety of what they're facing? Can you encourage them to go to a therapist or link counseling and making sure that they're able to get the resources they need? Those things help to promote resilience. That's within the clinical walls. And certainly outside of those, when I was talking about being a scholar activist and trying to get involved in the community. So for example, with parental incarceration, are there local groups? And I don't, Dr. Schlafer will have to tell you for Minnesota, but are there local groups that you can get involved in to help to break that school to prison pipeline? Are there things that you can do to support those that have had a parent incarcerated? Can you advocate for closer distance with respect to incarceration, like so that the kids can actually go visit their parents? Because sometimes they're incarcerated miles, hundreds of miles away from their parents. So what are the things that you can do outside of your clinical home, outside of the hospital, to promote resilience for the things that you care about that impact your patients?
Thank you so much. This was just an absolutely phenomenal talk. We're delighted to have you with us. I hope we'll be able to have you back for more talks in the future.
Oh, I would love that. Thank you for the opportunity. It's been wonderful.
Thank you very much. It was a great talk.
Thanks, Nia. Good to see you.
Bye. So
Bye,
good to
everybody.
see you.
Stay
Bye.
warm.
Bye.
All right, take care.